A new restorative material for repairing fractured incisors came on the market about 24 months ago. The material is called Nuva Fil, N-U-V-A-F-I-L, which is a trade name. This is an ultraviolet light sensitive composite resin. In other words, once this resin is mixed, it will not set up in 1 minute or 3 minutes or 30 minutes. It sets up only through the application of the ultraviolet light, which is made also by the same company that produces the material. There is a screening mechanism built into this ultraviolet lamp so that the harmful rays are screened out. Nuva Fil material comes in 3 shades: light gray, light, and light yellow. And for the average situation, light gray is the best. The Nuva Seal material is the liquid type plastic that you will study in the next part of this module, dealing with pit and fissure sealants. It is necessary that the tooth be kept dry. This can be done with cotton rolls and saliva ejector or a rubber dam. In this case, the rubber dam was used to isolate saliva. The etching solution is now being applied. This is 50% phosphoric acid buffered with 7% zinc oxide. It is allowed to remain 1½ minutes, and you should etch 2 to 3 millimeters beyond the fracture line. Now, this tooth was cleaned with pumice prior to this procedure, but do not use a fluoride pumice, as this will reduce the degree of acid decalcification. If the tooth were a new fracture, in other words, happened in just the past week or so, cover the dentin with Dical or some other solid material to protect the open dentin tubules from the acid action. Do not rub the acid on the tooth. Pat it gently with cotton. This acid etches the end of the enamel rods, and it roughens the surface, and any overt rubbing action will actually break down some of the etching roughness that you have. Now, when doing this to primary teeth, it is necessary to sandpaper very slightly the surface of the enamel first. The end of the rods on primary enamel lay over, so that you do not etch the ends of the rods, you are etching the sides of the rods. And this occurs approximately to a depth of 25 microns. So in doing this to primary teeth, it is recommended that you use a sandpaper disc and knock off the outer 25 microns of enamel prior to etching. The acid is now being washed off the tooth with just water. Do not touch the tooth with any instrument at this point, as you will break down some of the roughened surface. You cannot see it on the videotape, but in the clinical situation, that portion of the tooth that has been treated with the etching solution will look white and bleached. The tooth is now air dried. If you would happen to feel the enamel surface where the acid has been applied with the end of an explorer, it would distinctly feel rough. If no further treatment were done on the tooth at this time, and it were exposed to saliva, within 24 hours it would remineralize this surface from salivary chemicals. The next is the thin layer of Nuva Fil. Pit and fissure sealant is applied with the brush to the etched area. This is also applied over the fractured dentin, or in case you had covered the fracture site with Di-Cal, you would paint right over the Di-Cal with one layer of Nuva Fil, which is the same material as the pit and fissure sealant explained in the next unit. The directions for the Nuva Light, or the ultraviolet light gun that you will see in just a few moments, are on the cover of the box. It must be handled in a certain way in order to be effective. This liquid Nuva Fil flows into the rough places and gains physical retention. It requires a 30-second exposure to the ultraviolet light in order to set. You are to hold the end of this directional rod as close to the tooth as possible, but do not touch the Nuva Fil. Once that little jar of Nuva Fil is activated, and you secure this from the pedodontic department, it is good for 24 hours only. In this particular clinical case, we are using the light 30 seconds from the labial surface and 30 seconds from the lingual. This will harden the Nuva Fil, and then the Nuva Fil becomes the bonding agent with a chemical bond with the Nuva Fil filling material. There are two techniques to use Nuva Fil. One is the build-up, or just sculpting the material to the correct configuration, or in the case of large fractures, you can use this in a regular plastic crown form. The light will penetrate the crown form and set the Nuva Fil material. There are other videotapes to be seen with this unit to demonstrate differing placement techniques to use. Now the Nuva Fil itself, 3 shades in 3 separate jars, has to be activated also with 1 drop of the special activator, which actually is what makes the material ultraviolet sensitive. Once the Nuva Fil, the jar of Nuva Fil, has been activated, it is good for 3 months if you keep the lid on it, except to remove material, as daylight and fluorescent lights also have ultraviolet rays, and to leave the lid off the jar, you will set the material up short of 3 months. Use plastic instruments with this. Do not use steel, as it will discolor the material. And what is being done right here is the Nuva Fil material, and in the correct shade, is being placed on the Nuva Fil and molded or sculpted into the correct form. Other videotapes demonstrate the use of a crown form to place this material. Now the ultraviolet light will only penetrate this Nuva Fil material to a depth of 1 1/2 millimeters. And in the case here, we will cure from the labial and again cure from the lingual. If your material is thicker than 1 1/2 millimeters in any particular place, or thicker than 3 millimeters, so you can't reach it from the labial and the lingual, then it is necessary to build it up in incremental layers, adding your material, curing your material, adding the material then to the cured material, and re-curing the new material. This is a relatively small fracture in this case, though, and we can do it all with one application. Now the Nuva Fil is placed on the Nuva Seal because you have chemical bonding of the two composite materials. It really is immaterial as to whether you use the rubber dam or not. If you can keep the site absolutely dry, free of saliva, free of the patient's tongue, free of any particular hemorrhage that might originate in the gingival tissue, then do not use the rubber dam. One final application of some more material on the lingual, and you notice the material tends to puddle just a little bit. And we'll get this molded back into the correct shape in just a moment and then cure. One little rough spot right there at the cervical extension of the fracture. It is helpful to keep the material from sticking to this plastic instrument that you can dip it and then shake it off in alcohol. And the alcohol that you put on the restoration will evaporate. I believe it's just about to the proper form that we wish. And we'll proceed now to cure this material. Using the same ultraviolet light, now it requires 1 minute curing time. And because the material is thicker than 1 1/2 millimeters, we will cure 1 minute from the labial and 1 minute from the lingual. If the material is too thick to cure in this manner, you must build it up in incremental layers. The light will penetrate 1 1/2 millimeters only. Some remarks about the light while this is being cured. Once it is plugged in and turned on, you do not have the proper ultraviolet ray production for 10 minutes. So you just can't plug it in, turn it on, and use it immediately. You have to do a little prior warning and give it a 10-minute warm-up period. When you have finished the procedure and have turned off the Nuva light, do not put the lid on for at least 10 to 15 minutes, as this produces a great amount of heat, and if you don't give it ample cooling time, it will burn out the bulb, which incidentally is worth about $70. While you are using it, and the instrument is turned on, the ultraviolet light gun must be kept over the air cooling vents on the machine. I would suggest that you go to the dispensary prior to completing this module and look at the Nuva light. You don't need to check it out, but you can just look at it right there and read the directions on the lid very quickly. Now, once this material is cured, you're ready to do any finishing that needs to be done prior to putting on now our final overcoat layer of Nuva Seal, the same that was put on the tooth initially. So that actually you have a sandwich effect, or a 3-layer effect: Nuva Seal, and then Nuva Fil on top of that, covered with Nuva Seal. Now, in the case of the small fracture such as this, occlusion was no, and we went right ahead and finished the restoration at this time by just eyeballing the situation. On large fractures, or where you may have a troublesome occlusion, at this point, remove the rubber dam, go ahead and let your material get wet, adjust the occlusion with articulating paper, sandpaper discs, or green stones, and then when the occlusion is correct, re-isolate the tooth either with rubber dam or cotton rolls and saliva ejector, dry it very carefully, and then you may put your final seal coat on top of the filling material. Occlusion in this particular case was no problem, and you will find it not a problem in many of the fracture incisor situations, as the child will tend to have a class 2 of malocclusion, or his maxillary incisors are in a labial position, and that's why they fractured when he fell down anyway. Using here just sandpaper disc for final finishing, you want to have a feather edge at the junction of your etch and non-etched enamel, and this can be picked up with an explorer. This can be done with green stones or sandpaper discs, whichever is convenient. It will need to be the dust blown off prior to our final sealing layer. And remember this, the better that you form the material before it is cured, the less final polish you will have to do with either sandpaper discs or green stones. The rubber dam can be removed for this, and then the tooth re-isolated and re-dried, air-dried, before your final third layer is placed. If, when you remove the rubber dam, the material pops off, then this is your warning that either your etching was incorrect or you need to etch more than the recommended period of time. Once the material is finished, it is extremely strong. The patient needs observe no special precautions when he leaves the office. The only one of these I have seen that has fractured after the patient left the office, it was not the Nuva Fil that fractured. The patient fell down again. The Nuva Fil did leave the tooth, but it took some tooth enamel with it. In other words, the enamel fractured rather than the junction of the filling material with the enamel. Just a final check now. Give you an opportunity to see this from the lingual. It is not necessary to use any anesthesia with this procedure. This patient is experiencing his first dental experience other than an examination, has no anesthesia, and as you can see, he's more interested in watching the TV monitor than in what is going on in his mouth. Final check of the feather edge, making sure there is no overhang, that we have not applied material beyond the etch. Material beyond the etch will not stick, it will fracture off and then give you a rough margin, which could be conducive to plaque formation and poor cleaning. Final blowing off of all dust and powder, and then we will cover the entire restoration and with a third layer, or the second layer of the liquid Nuva Fil pit and fissure sealant. Details on the chemistry of this material will be found in the next portion of your PDM1 module, dealing with pit and fissure sealants. The Nuva Fil is an offshoot of the development of the pit and fissure sealants, and in actuality was developed by Dr. Michael Bonacore at Eastman Dental Dispensary. This material actually that we're applying right now actually gives the appearance of having glazed the restorations, just as you do with porcelain. Baking porcelain, you put on a final glaze layer to give it a sheen. Now the light is applied. "30 seconds from the labial, 30 seconds from the lingual, and then the material is finished. Maximum strength on this material is present at the conclusion of the treatment, and it is an extremely strong composite and requires about 5,000 pounds force to break its attachment from the etched enamel. A reminder also, when doing this on primary teeth, before you etch, you must remove 25 microns of outer surface enamel where you intend to etch it, to get rid of the outer prismless layer of enamel that is present on primary teeth. 25 microns is not a great measurement. I prefer to do this with just sandpaper disc. Material is cured now, and we're going to remove the rubber dam. We won't show you the removal in order to save time, but you can see how the final restoration appears in the patient's face without the rubber dam present. When you plan to place one of these in a clinical patient, it is necessary to make a reservation for the Nuva Light with the dispensary on your floor. We have only 3 Nuva Lights in the entire building. Good view here of the lingual. You can notice the shininess of that restoration after that last application of Nuva Fil. Here's the restoration after the rubber dam was removed from both the lingual and the labial. Now the other fracture in the maxillary right central probably will require a crown form when it is placed in order to form a good mesial surface. But this restoration in that left incisor, there are patients checking it out now. They just produce fantastically good restorations with a minimum of trouble to you and a minimum of discomfort to the patient. As I said before, this is this boy's first dental experience other than an examination. And you might notice also he has a mandibular crossbite on the right-hand side. Final close view makes a very excellent restoration and makes mothers and children very pleased that it's so easy and relatively inexpensive to repair fractured incisors. About 50% of all children fracture an incisor during their childhood, and if those maxillary incisors a labial version, your odds go up to about 85 or 90% of these children will fracture these incisors.